Dr. Theron, Philippa, Lelani, thank you very much for joining me today. The reason why I invited you here is because in recent years, in our own practice, we have seen that patients are becoming more involved in the decisions around their healthcare. They are more informed than they were a few years ago. And they also ask more questions, meaning they have a need for quality information. So we decided, let's get together, have a conversation about breast cancer, and then while we talk, we can hopefully empower them with information that'll put them at ease about this process that may ultimately lead to a breast cancer diagnosis for some women. So I'm going to start with the first thing that springs to mind when you think about breast cancer, and that is early detection. And I'm going to ask the doctor in the room, what does early detection actually mean? And is there a link between early detection and outcomes?
Yes, I think it's a very good question. Early detection is absolutely essential, and that is what we aim for with screening mammography. And the earlier you detect cancer, the more treatment options there are. And very often the extent of treatment is not as extensive as with advanced or infiltrating carcinoma. So patients might get away with a lumpectomy where they just excise the tumor or the area of abnormal DCIS, which is the ductal carcinoma in situ. You might not need a mastectomy. You might not even need chemotherapy afterwards. So if cancer is more advanced at diagnosis, obviously your treatment options become more limited and also usually more intense treatment necessary.
If we talk about early detection, is there a definition for early detection?
I think that's probably what we mean when we say early detection. So I think mammography, the purpose of mammography, with screening mammography, is to diagnose cancer before it's palpable. So before a clinician or yourself, before you feel a lump. And then very often on mammography, for instance, the cancer that you can diagnose would be before there's a physical lump on ultrasound or mammogram, just with abnormal microcalcifications. That's the earliest form of breast cancer. And that is what we call ductal carcinoma in situ. So you've got malignant cells inside the ducts, but they haven't infiltrated through the walls of the ducts. So it's not into the adjacent tissue, and therefore there's no palpable mass. And that's actually when you want to diagnose breast cancer.
So that means that self-examination, while it is important, is not necessarily enough.
Definitely. I can't agree with that more. It's important to self-examine because sometimes a cancer starts growing after your recent mammogram that was normal 6 months ago. And if there's a lump now, please feel for it, search for it, and find it earlier than next year's mammogram. But definitely screening mammography from age 40 for women with the average risk. If you are known to have a very strong family history, then you might even have to start screening earlier than 40.
And I guess patients have to talk to their own doctor to find out what that risk would be and about genetic testing and so.
Yes. And if you have a strong family history, for instance, mother and sister or daughter, and especially if anybody was diagnosed before the age of 40, that raises a flag to say there might be a genetic component. And then you might be sent to a geneticist to give you counseling and decide whether you want to be tested yourself.
Now that we talk about mammograms so much, Lelani, I think the next question is for you. Does a mammogram hurt? I think one of the questions we hear most often.
I've had a mammogram recently, and I did not feel any pain during the procedure. What I felt was when it's the same type of pressure when you lie on your tummy. That's what I felt. I know everyone experiences it differently, but from my side, it's not painful. It does have a bit of discomfort, but it shouldn't be painful. And we are also trained as mammographers to ensure that the patients feel comfortable and that they don't experience any pain during the procedure.
And can a patient come for a mammogram if she has breast implants?
Definitely, we do them often. As I said, the compression is not that much. Especially for patients that have implants, it's the same type of compression as when you would be lying on your tummy. And we do change our positioning and our technique a little bit, but we can definitely do in patients with implants.
One of the things that might keep women from a mammogram is their busy life. And maybe a mammogram is the last thing on their to-do list. How long does it take?
So we usually ask the patients to be here 15 minutes before the time, just to handle all the paperwork and get everything, all the admin out of the way. Then we would ask them to undress, put on a gown, and then we'll take them through for the mammogram. The mammogram itself takes about 10 minutes. We'll ask them to fill in a form, and then we'll do the 4 images. Then we will do the mammogram. Then when we're done with that, we might do an ultrasound as well. That usually takes about 15 to 20 minutes. So all in all, I'll say about 30 to 40 minutes, depending on what the extra examinations we need to do, or extra views, or extra procedures we need to do.
Philippa, my next question would be for you. Our patients have noticed that we support a breast cancer charity called ILoveBoobies. Many of them wonder about it. Please tell us about ILoveBoobies. Where does the name come from? That's a point of interest. What's your mission, and what's the relationship with ACP?
Okay, so the name doesn't have an extraordinary story to go with it. I think it needed to serve 2 purposes. The name needed to raise an eyebrow, because we want people to be able to speak about cancer, and we want people to think about it. We need it to be top of mind. And secondly, it's a serious thing to talk about, and bringing a little bit of humor into the conversation can sometimes soften a difficult conversation. When you're on the trails wearing your I Love Boobies socks and somebody runs up behind you and says, "Hey, I also love boobies," which every man that passes you on the trail will say, it's a great conversation starter. And that's part of the purpose of the name, is to be able to have those conversations, and to not make it always a serious thing, to start it off as something soft and something that people can easily relate to. So what do? We provide free breast health screenings for women in underserved communities. So these women often face barriers that might be locational. So they live rurally, and they're unable to access medical facilities easily. They may be restricted by financial concerns. Very often women that are working on farms or in warehouses, in the places that we go, are faced with, "Oh, I found something," or "I'd like to know more about it. I need to get somewhere to a medical facility," or "I need to put food on the table for my children tonight." And we know as mothers what that choice will be. Or it may be social stigma that's attached to illness, that sometimes prevents women from seeking treatment, knowledge, or experience around breast cancer or many other diseases and illnesses. So that's what we do. We take our screenings to underserved communities. It can be just within an open community environment, but we prefer to do it with an employer, because then we can use their services to also be part of the process. We take our nurses to their facilities, and we'll screen the women that are on the premises.
And now that we're on the topic of awareness and self-examination, how often should a woman do self-examination, doctor, and what should she feel and look for?
So once a month is what is suggested, and I think one has to examine your breasts, stand in front of the mirror, move your arms, and put your hands in your hips and see how the breasts move. Look for anything asymmetric, so changes in the nipple, changes in the skin, sometimes a visible lump or asymmetry that's new since the previous time you looked at your breasts. And then I think the best way is to take the fat side of your finger and in concentric circles work your way around, starting in at the nipple and going further out, and feel for something hard. Sometimes just a pea size, smaller to a hard lump, can be a sign for cancer. And then the other thing that to keep in mind is to always examine the armpit as well, because that's where the lymph nodes will become enlarged. So one hopes that you will find breast cancer before you get enlarged nodes, but that could also be something that draws a patient's attention to something that is going wrong.
Okay, and I guess then the recommendation is to make booking with your doctor or a mammogram immediately. You don't delay. Absolutely. What do patients feel when they come for a mammogram?
Most patients, when they come here, are very anxious, especially the newbies, because they don't know what's going to happen to them when they walk into a mammography department. And they're anxious because they don't know what the procedure entails, they don't know what the results will be. So for new patients, that's definitely that part of the anxiety. And then for the patients that have had mammograms before, it's definitely the results. They are anxious about the results. And patients that have had breast cancer before, they are also, we find that they are a little bit anxious.
What do you do to put them at ease?
We talk them through the procedure. Our mammographers are specially trained to do mammography. It's a specialized modality, so we get a certificate in doing mammography, and we are trained to put patients at ease, to make them feel comfortable. We talk them through the whole process while we're doing the mammogram, while we're doing the whole examination. We talk them through it, and we just make them feel at ease before we even start. So,
I know this is not for every patient, but sometimes a mammogram would be followed by a breast ultrasound. Do I have that information correct? How does that work?
So we don't use it as a primary screening tool. Mammography is the gold standard for breast imaging, but there are certain cases where we do breast ultrasound, especially for patients that have breast cancer previously, or patients with implants, or very young patients. So we don't always do ultrasound on everybody.
Okay. But it is possible that if they come in and they expect it to come from mammogram, they might be asked to do an ultrasound at the same appointment?
Yes, definitely.
Yeah. Dr. Salomine, this one is for you. So once someone is diagnosed with breast cancer, what are the next steps? Is there a set pathway from diagnosis to treatment, or does it look different for every patient?
Maybe one step back. Let's not say you don't diagnose breast cancer, but the mammogram and the ultrasound are suspicious for breast cancer, because you can never diagnose it with a mammogram. You can have a high suspicion or a low suspicion, and you can say that you need further investigation. And the way to diagnose it is always with a tissue diagnosis. So if the patient presents with a large palpable lump, then sometimes the surgeons will do a biopsy themselves in their rooms, and we don't have anything to do with that. But very often, especially when it's just abnormal calcifications, or when it's a tiny 6 millimeter or 7 millimeter little lump that you can't feel clinically, they ask us to do a biopsy, and then it's an image-guided biopsy. So in the case of anything that is visible on ultrasound, we will always try to do the biopsy ultrasound guided. And if it's not visible on ultrasound, but there are calcifications visible on mammogram, or there's maybe a tiny spiculated area, then we can do what we call a stereotactic guided biopsy. And then we aim for the calcifications or the little spiculated area, and we can biopsy that while the patient is on the mammogram machine in compression. And then once we have the pathological diagnosis, then that gets sent to the oncologist and the surgeon, and they plan. There's not one size fits all with that treatment.
And then I think you mentioned earlier that sometimes after patients went through successful treatment, they have to come for follow-up imaging, and that would also be done at a radiology practice, right?
Yes. So usually the follow-up is coordinated by the oncologist or the surgeon, and they decide how often they want the patients to come for follow-up and what type of follow-up. It's usually a mammogram and usually a breast ultrasound, like Lelani mentioned, every year after your diagnosis, because like I mentioned before, you are at higher risk for contracting new cancer and for local recurrence because you've had cancer before, sir.
Okay. So often you would walk a rather long or a relatively long road with one single patient. You would see the same patient for many years.
Yes, we do build relationships with our patients, especially the ones that come every year. They sort of recognize you, and we recognize them as well. So it's quite nice to build relationship with the patients. Yeah.
And I guess that's something that makes SCP for me very special, in the way that they have compassion with patients and build that rapport with patients. We often get that feedback as well. Philippa, tell us a little bit more about your relationship, ILoveBoobies' relationship with SCP. Where is the connection?
So the amazing thing about the connection is that it closes the loop for many women, because going to rural areas or to areas where women are working for a weekly wage or a daily wage, and educating them about breast cancer, about knowing what their normal is about. So self-examinations is important and it's great. We need to leave that information and knowledge with them. However, if the anomalies are detected during a screening, we can't just hand over a referral form and walk away, because many of those women don't have access to the next step. Possibly they don't know what the next step is. And secondly, if they do, all the things that need to fall into place for them to be able to access that can be very restrictive. So SCP and our other radiology partners provide us the service of a donation of mammogram for the women that are found to have anomalies during a screening, biopsy if required after that. And so we're able to get these women all the way through the referral pathway, from picking up an anomaly right through to diagnosis, and then feeding them into the state hospital so that they can get treatment or surgery, whatever's required.
The relationship with ACP, does it improve outcomes for those patients? It's quite early days when you get people or patients to surgery.
It's incredibly smooth. It's a world-class standard of care for these women that very often may not have even looked into whether they have something that they're aware of or not aware of. They may not even have gotten to that point of knowledge about that. And an example is that in August, on the 9th, we did a screening in a community. There were several women there that had anomalies. One of them had a mammogram and went on to have a biopsy, pathology, and was then diagnosed and sent to Radiology for treatment or surgery within 20 days of her having come to a screening. So that's an incredible story. It's also a story that she can take home. It's a story that's going to feed through her community. So we are doing something for her, but actually that there's a ripple effect that goes with that. Remember that not all the women that come for a mammogram are going to go all the way through to surgery. A mammogram often rules out anything that is of concern. And I think the word and the message that goes with that woman that has had that experience travels into a community, and that's important.
Right. And then what are some of the known causes and risk factors? Maybe just stick to risk factors.
Okay, so I think the known risk factors are genetics. And so if there's a known BRCA1 or 2 genetic mutation in the family, or if the patient is herself known with such a mutation, there are also a few other genes that increase one's risk for breast cancer. Other risk factors include obesity, smoking history, patients who started menstruating very early or have their menopause quite late, and then a general family history also. Even if there's not a known genetic mutation, if you have a mother or an aunt or a grandmother or your sister or your daughter with breast cancer, it does increase your risk for breast cancer.
We often associate breast cancer with older women, especially because the recommendation is to start getting screenings from 40 upwards. Does it mean that young people don't get breast cancer? And does it mean that me don't get breast cancer?
That is definitely a very important question that you've asked. So young women can get breast cancer. We have had a few diagnoses in this year of a 22-year-old, a 26-year-old, a 28-year-old woman. If a young woman feels a lump, she needs to get attention to it. They'll come into the practice. We'll usually start with a breast ultrasound. If we see a lump, we might go on to do a mammogram to look for calcifications, and a biopsy might be necessary. Having said that, very often the lump is actually what you call a fibroadenoma, which is a good-natured, benign lesion, very common in young women. And if we find that, then we will just suggest follow-up imaging to make sure that it doesn't grow. So it's not necessary that they get a biopsy in those circumstances. Then the question about breast cancer in men, it is much rarer than breast cancer in women, but 1 in 100 of diagnosed breast cancer would be in a man. So they're definitely also genetic. So if there's a BRCA history or strong family history. So I think the take-home message there is, if a man feels a lump behind or close to the nipple, it's not normal and you need to have it checked out.
Doctor, can you tell us something about safety and radiation? in mammograms?
So it's very important to keep radiation as low as possible. The ALARA principle in radiology states that we try to limit radiation to what is necessary to make a diagnosis. And I think with a screening test, the benefit always needs to outweigh the risk. So the risk of such low dose of radiation is negligible compared to the benefit of early diagnosis of breast cancer. And that is also why we only start screening women regularly at age 40, because it's so much more common for women. Most breast cancers are diagnosed above 40, and much less are diagnosed younger than 40. And that is why we only do the annual screening in patients 40 and above.
Okay. So my last question to you, Philippa, would be, where can our patients find out more about ILoveBoobies and how they can support ILoveBoobies?
I think the go-to place for most people is social media. So Instagram, Facebook, we're on TikTok, LinkedIn, all the usual places. That's a good place to see what's going on, what we're doing to raise funds, what activities are going on. Also our website, ILoveBoobies.co.za. We have an e-commerce store. We are a self-funded charity. We do not have government funding. We don't have corporate funding. So we have to raise all our funds ourselves, which means that we sell merchandise, activewear, as well as having many activities and events and activations on the go at any given time. It's the Imagine Challenge, which is our biggest fundraiser of the year, which gets people up off the couch if they aren't. And those that are active, keeps them active, set goals for yourself, and you have the whole month of October to achieve them. So check out that on the website, the Imagine Challenge, but you'll see it everywhere on our social media and all the places that you consume that kind of, that kind of stuff.
Thank you. Lelani, where can patients make a mammogram booking?
So we have a tab on our website that says make a booking. So they can just click on that and they can fill in a form, and then someone from one of our branches will contact them. Or they can just contact one of our branches. We have a few in Cape Town and on the West Coast. So they can just contact one of our branches and then they can make a booking.
And then, Dr. Theron, if there's one message in terms of awareness to everyone out there about early detection breast cancer, what would that be?
If you can, have a screening mammogram every year from the age of 40 and never ignore a new lump that you feel in your breast.
No matter the age, no matter the gender. Yeah. I think we've shared a wealth of information. It's been a very interesting conversation, and I want to thank all of you for taking the time, sharing your knowledge. I'm pretty confident and hopeful that this will help some women out there to get themselves checked and to get the diagnosis they may need for successful treatment. We appeal to you to get yourself checked.